Okay, so good morning, everybody. It's always a privilege to speak at this meeting and certainly to serve in advisory and supportive capacity for Debbie's foundation. And I certainly encourage all of you not only to participate in the educational activities, but the advocacy program that occurs annually in February, where we have caregivers, patients, survivors that meet with their legislators or their legislative associates in Washington to lobby for support for cancer research funding. And certainly if you've not attended that event in the past, I certainly encourage you to do it. It's quite empowering and quite a powerful experience to share with people from around the country to advocate for awareness and for research funding. So I'm going to talk about non-surgical treatment for gastric cancer. These are my disclosures. So as you can see, stomach cancer is a disease that varies hugely in incidence around the world. Certainly in East Asia, in countries like Japan and Korea, it's one of the most common cancers. China accounts for more than 50% of all the world's gastric cancer. And it also is a disease that's more common in Eastern Europe and tropical South America. But you can see that in Western Europe and North America, this is a relatively uncommon disease, and we just do not have effective screening because this cancer actually continues to decrease in incidence. It is a major health problem, but because it's less common, it makes high-volume screening in the United States very difficult. So in the US in 2017, if we combine esophagus and gastric cancer together, we'll see nearly 45,000 Americans a year. It's about 3% of US cancers. And again, we are seeing a decrease in incidence in more distal gastric cancers, which we think are related to Helicobacter infection, and a shift in the epidemiology to cancers of the more proximal stomach near the esophagus. And survival has improved with these diseases over the last 3 decades. Stomach cancer used to, if you look back in the 1970s and 80s, it was a 16% long-term survival. Now we're up to almost 30%. So still a long way to go, but there have been improvements in survival. For the treatment of gastric cancer, we have more effective therapies. We have consistently better surgery, and we know that treatments after surgery, adjuvant treatments, improve outcome as well. So again, in the West, there's no effective screening for gastric cancer. This disease only occurs at about 10 to 20% the incidence of screen cancers like breast, colorectal, and prostate cancer. And also familial stomach cancer is pretty rare. Probably less than 5 to 10% of cases do run in the family, so it can be difficult to identify high-risk families because a familial component is really not that common. And as a consequence, because we don't have good screening, many patients present with symptoms. They have symptomatic disease. Up to 30 to 40% of patients do present with stage 4 stomach cancer at diagnosis. And I know Dr. Parikh alluded to this earlier, but even in patients that have potential surgical candidates that we might operate on, about 20 to 30% of these patients have tumor that's spread in the abdominal cavity, or those washings that he talked about, doing washings of the peritoneal cavity. They're positive, so that when we attempt surgery in about 20 to 30% of patients, we do find stage 4 disease, in which upfront chemotherapy probably should be given first. And even with aggressive treatments, the recurrence risk after surgery may exceed 50%. So this can be a difficult disease to treat. So adjuvant therapies, treatment after surgery, does improve outcome in gastric cancer. These are the common approaches either after surgery or sometimes before surgery that are applied to improve outcome. Kind of the old, I know Joel Tepper will talk about the role of radiation, but kind of an older approach in the United States was after surgery to give postoperative radiation and chemotherapy. And this was actually one of the first approaches to be shown to improve survival after gastrectomy in patients with stomach cancer. And we did result in a modest improvement in survival at 10 years, about 10%. So that translated into about a 30% reduction in the risk of recurrence. Certainly 5-FU and radiation after surgery is a standard approach. And a recent US trial showed that intensifying the chemotherapy after surgery did not improve the outcome, that if we gave the ECF regimen as opposed to 5-FU, there was no benefit. Increasingly, in the treatment of stomach cancer, we're now giving preoperative therapy. Pre-surgery chemotherapy, then surgery, then postoperative chemotherapy. This was an approach that showed benefit from Great Britain, where perioperative chemotherapy with the ECF regimen again improved survival. This translated again into about a 25 to 30% reduction in the risk of recurrence. And in these studies, radiation was not used. Then the biggest experience with upfront surgery followed by chemotherapy after surgery comes from Asia. Dr. Parekh talked about the need to do very good surgery. And I think the Asian studies has shown that if you do really good surgery, you take lots of lymph nodes, you do a D2 resection, that you probably can just give chemotherapy after surgery, that the role of radiation therapy may not be needed in some patients, that chemotherapy alone, either 5-FU based or 5-FU and platinum-based chemotherapy may improve outcome. And all of these approaches that employ chemotherapy with or without radiation, again, reduce the risk of recurrence by about 25 to 30%. So there's no absolutely preventive treatment after surgery, but the use of chemotherapy in combination with surgery does reduce recurrence, and that is part of standard of care. So what about patients with initially non-operable tumors that they're still localized? Sometimes you've got patients that have bulky tumors and lots of lymph nodes, and sometimes the surgeon doesn't want to go in and operate right away, because if you're going to do a surgery, you really have to get clearance of the cancer. You have to go in and get clear margins and get all the lymph nodes out. You don't want to leave any cancer behind. So sometimes these patients might be considered borderline operable, and there might be a consideration for surgery after chemotherapy. So if patients have a good response to chemotherapy, then they might be consideration to operate later. And sometimes we'll also add radiation therapy to the chemotherapy, again, to try and induce the best response before operating. And then patients would be reassessed for surgery later. These are the patients that might benefit from more aggressive upfront chemotherapy. Typically, most times we'll give a 5-FU drug and a platinum agent, but if we're really trying to push the response as intensely as possible, we might add a taxane. We might do a taxane plus 5-FU and platinum, the modified DCF or the FLOT regimen. And even primary chemotherapy and radiation, there's a historical literature in stomach cancer, goes back many decades, that some patients that get chemotherapy and radiation actually have a complete response pathologically. There's no cancer remaining at surgery. So these are patients that might benefit from intensive chemotherapy, potentially radiation, but not always immediate surgery. So this, I think, is an important question to ask. Many patients ask me if they have metastatic disease, why shouldn't I have my stomach taken out? Don't you want to take out the primary cancer? Isn't that going to help the situation? And it's always important when you have major cancer questions to ask the question in the context of a study. Typically for stage 4 metastatic disease, we're going to give patients chemotherapy and not necessarily rush to do surgery. And I give the Japanese a lot of credit because they actually asked this question in a study. In patients with metastatic stomach cancer, what is the role of taking your stomach out up front as opposed to just giving chemotherapy? So this was an important study that was published last year called the Regatta trial, where they took 175 patients with newly diagnosed stage 4 metastatic gastric cancer. Obviously you don't want to do upfront surgery on somebody that has tumors in many places, liver tumors, lung tumors. So they selected patients that had pretty limited stage 4 disease, patients with limited peritoneal or abdominal metastasis, patients with limited lymph node metastasis, and then they did a coin flip. Half of the patients just went to get chemotherapy without surgery, and the other half of patients had gastrectomy, had their stomach tumor taken out first, and then received chemotherapy. So really asking the question in a trial, does upfront surgery have a benefit? And the results are interesting from this, because many patients and doctors feel more is better. You got to be more aggressive. You got to do surgery. And this study actually showed that survival was inferior. That patients that got upfront surgery did worse. They did worse. Their survival was poorer at 2 years, 25 versus 32%. And because they had their stomach out, they tolerated chemotherapy much more poorly. So I think this is an important study because I think it's important data. They're important data to present to patients because patients say, why can't I have surgery? Well, here's a study that showed that if you get surgery when you walk in the door, you may actually do worse. That you shouldn't have surgery up front. You should get chemotherapy, and then whether or not you're going to get surgery, we can address that later. But this is an important study because I think it answered the question that for stage 4 disease, we probably should start with chemotherapy first. We shouldn't rush and operate because we actually may compromise how the patient is going to do. So more is not always better. So what are the issues then? Chemotherapy is really the mainstay of treatment of stage 4 metastatic disease because unfortunately, in some patients, sometimes curative surgery is not feasible. The goal of chemotherapy is to control the cancer and maintain the quality of life for as long as possible. There are potential for complete remissions in chemotherapy, but they're rare. So most patients, when they get chemotherapy, it's really to control the cancer and maintain the length and quality of life for as long as possible. And it's not one size fits all with chemotherapy. Every patient that walks in the door, you've got to make a decision that's going to be the best treatment for that patient. You have to assess their age, how functional they are they in good physical condition, do they have a lot of medical problems that might make chemotherapy more difficult to tolerate. But in most patients that we treat for stage 4 disease, a combination chemotherapy regimen is better than just giving individual chemotherapy drugs. So most patients we're going to give combination chemotherapy. In the vast majority of patients, 2-drug chemotherapies are the best. We typically, single chemotherapy drugs, we're going to do that treatment in really older patients that aren't well, that aren't going to tolerate the rigors of more aggressive treatment. And then at the other extreme, the 3-drug regimens, like adding a taxane to platinum 5-FU. Again, we talked about patients that we really need a response quickly, like these patients that might be borderline operable. Certainly patients that have a lot of symptoms, very symptomatic at presentation, we want to get a higher response. And also, these are not easy regimens to tolerate. These are treatments we would give to very high functional status patients, patients that are in good condition, younger patients without medical problems. And certainly, patients, this is an informed decision. You have to know what are the side effects of your treatment, what are the complications of treatment you're going to have to deal with, and is it better to get more side effects or to maybe use a lesser intensive regimen that's maybe more tolerable and maybe not necessarily less effective. So the old standard chemotherapy, very few oncologists do this anymore, but when I started practicing, the combination of 5-FU and cisplatin was standard treatment, but we would give the 5-FU through a port over 4 or 5 days. So we'd get a very high dose of 5-FU over 4 or 5 days, with very high doses of cisplatin. We do this once every 3 or 4 weeks. And the responses weren't too high. Only about 20 to 30% of patients responded. And with those treatments, the average survival time was less than a year. And these were pretty toxic treatments. In fact, I spent a good part of my early career trying to look at alternatives because this treatment is just so poorly tolerated and we had to do better. And we have done better. We have, I think, equivalent drugs that are better tolerated. The oral drug capecitabine is equivalent to continuous infusion 5-FU. We now use a lot more of the drug oxaliplatin, which is better tolerated than cisplatin. And we've kind of learned from our colon cancer colleagues that if we schedule the chemotherapy like we do in colon cancer, we give 2 days of treatment every 2 weeks, patients tolerate it a lot better. And the treatments may even be more effective than the old way we used to do things 25 years ago. So I'm not going to go into detail about this slide. This summarizes, again, I told you earlier that the way we advance the field is we do controlled trials where we compare treatments. And this slide summarizes the effectiveness of pretty much all the chemotherapy regimens that we use now. On the right hand of the slide, these are kind of the standard regimens, ECF, DCF. In the middle of the slide, these are treatments like Folfox and Folfiri. And if you look at the response rate, the RR, percent response, you look across this, the table there, you don't really see much difference in the responses. So these are really comparable treatments. Whether you give 2 drugs or 3 drugs, you get about, modern chemotherapy, about 40 to 50% of patients have major responses. Typically, patients are on treatment. Time to progression means how long are they on the treatment. It's about 6 months. So 6 months, that's an average, so that means that half of patients are going to get longer benefit. But if you look across the table, there's no difference in all these different treatments. They're all about the same. And survival time, unfortunately, still is a little bit less than a year. So regardless of whether you get 2 chemotherapy drugs or 3 chemotherapy drugs, the effectiveness is about the same, and survival is about the same, and 2 drug regimens tend to be better tolerated. So these are data from a trial from Germany, which I think firmly established that oxaliplatin was equivalent to cisplatin in gastric cancer. This was Dr. Albatron from Frankfurt, a leading investigator in Germany, compared 5-FU oxaliplatin versus 5-FU cisplatin. And if you look at again, this time on chemotherapy and response rates were the same. So oxaliplatin was equivalent to cisplatin. And many of our patients that we treat, I think the average age of diagnosis of stomach cancer in the United States is patients well in their 60s. And when they looked at patients over the age of 65, in the bottom part of the curve, that blue curve is the oxaliplatin, and the yellow curve is the cisplatin. So in patients over the age of 65, they had better outcomes with oxaliplatin. So based on all the data for oxaliplatin, combination treatments, a combination of 5-FU oxaliplatin is the preferred treatment. And certainly this study indicates that if you're older, you're probably going to do a lot better if you get 5-FU oxaliplatin versus 5-FU cisplatin. Here are data from the British study. This was a 1,000-patient trial that compared various chemotherapies, and they also compared cisplatin versus oxaliplatin. That's a survival curve. You don't see any difference. So oxaliplatin really equivalent to cisplatin in metastatic disease. The British study also looked at capecitabine, which is oral 5-FU versus infusional 5-FU, and there was no difference. So we have alternatives to the older 5-FU platinum, capecitabine, oxaliplatin, that are equivalent. And this is an Asian study also showing that capecitabine and 5-FU are equivalent treatments in metastatic disease. So this is, I always proselytize about this because, as oncologists, you got to be very careful. You want to give treatments that are aggressive, that are going to have responses, that are going to help patients feel as well as they can, but you want to minimize the negative effects. You don't want to give patients treatments or drugs that are going to be harmful. And I have always gotten into arguments with my British colleagues as to whether or not the drug epirubicin adds any benefit. Because, Folfox, 5-FU platinum, it's tolerable. It's pretty tolerable. You add epirubicin, you get hair loss, you get mouth sores, you get low blood counts, you get vomiting, and it hurts your heart. It's toxic to your heart. So why would you give this drug unless you are absolutely sure that it's going to help patients? Well, this is a study from France where they compared the British epirubicin regimen, ECX, versus Folfiri, 5-FU irinotecan. So 2 versus 3 drugs. So that is a time to progression curve. So that means how long were the patients on treatment. And the yellow curve is the ECX, and the blue curve is the Folfiri. So the Folfiri patients actually did better on this trial. They had better time on treatment, 416 patients. Response rate, so the response to chemotherapy was the same. So adding epirubicin as a 3-drug treatment did not improve outcome over the Folfiri treatment. Patients were on treatment the same time. Actually, patients came off treatment sooner when they got epirubicin. And the toxicity, the side effects for patients favored Folfiri. So this study was one of the first to really show that adding epirubicin added no benefit. And there are subsequent studies. I'm not sure if I have it in my slides. I don't have it. So there was a slide done in the U.S., a trial done in the U.S., where we compared FOLFOX versus ECX, and there was no difference. So many oncologists, I encourage oncologists not to use epirubicin. It adds side effects and no clear benefit. So at the other extreme, we talked about 3-drug chemotherapy treatments, 5-FU, a platinum, and a taxane, versus 5-FU platinum alone. Again, that's a much more intensive treatment. This is the trial that Dr. Ajani ran in the US and Europe. DCF versus CF, and if you look down in the table, RR is response rate. So the response was a little higher for the DCF, 37% versus 25% for platinum 5-FU, and there was a very small survival benefit. But look at the side effects. This DCF, grade 3 and 4 means really severe side effects, some of which would wind you up in the hospital, and 82% of patients had life-threatening low blood counts. And if you look at the bottom, patients that were taken off therapy for adverse events, 50% of patients stopped this chemotherapy because they got too sick from the treatment. So another argument, again, that more is not better, and perhaps we should give 2 chemotherapy drugs as opposed to 3. But there was a survival benefit. It was modest, but at the cost of a lot more treatment-related side effects. So my colleague, Dr. Shah at Cornell, tried to modify this DCF regimen, giving lower doses and giving it once every 2 weeks. And he did show this modified DCF regimen. You could maintain response to treatment, maybe lessen the side effects a little bit, but it's still pretty toxic. And again, this modified schedule is getting more popular. But again, really, most patients are really going to be candidates for 2 chemotherapy drugs. This is still a quite toxic treatment that's not appropriate for all patients. And again, the age question comes in. Obviously, we don't want to have age of the patient be the deciding factor in how we treat them, but many series do show that as you get older, you have more side effects from chemotherapy. You have more blood count issues, more fatigue. This was a trial that, again, from my colleague, Dr. Albetron in Germany, where this trial was called FLOT 65. And actually, he looked at patients 65 and older and compared FOLFOX, 5-FU oxaliplatin, with or without the 3rd drug, without the taxane. 143 patients, the median age was 70. He compared a FOLFOX schedule with or without the addition of docetaxel. And the response was a little higher for the taxane regimen, 49 versus 28%, but there was no significant difference in survival or the time that patients were on treatment, and patients had a lot more side effects when they got 3 chemotherapy drugs. So if you look on the upper panels there, you don't see any survival difference on the right, whether patients got 2 drugs or 3 chemotherapy drugs. So I cite this study to patients. The patients want to know, why are you making a decision about treatment? And we like to base our decisions on controlled studies where we've proven that one treatment is better or not better than another. And this study, at least in patients 65 and older, does not show a benefit for 3-drug chemotherapy versus 2 drugs. I think studies like this are important because we realize in chemotherapy and oncology that one size does not fit all. You can't treat every patient the same way that when they walk in the door. You've got to individualize your treatment decisions to each patient. So what happens when 5-FU platinum doesn't work anymore, when it stops working? We now have controlled studies that show that second-line chemotherapy, secondary chemotherapy, does improve survival modestly compared to no treatment. These are studies from Asia and Europe. The study on the left looked at no treatment, just medical care versus treating patients with either Taxotere or irinotecan. And you saw the blue curve is the chemo curve. The patients did better. And on the right side, this is a British study where they compared Taxotere versus medical care, and patients also did better when they got Taxotere. So these studies did show that secondary chemotherapy does improve outcome, and if patients' tumor grows on 5-FU platinum, then we should think about giving them either a taxane or irinotecan as a secondary treatment. So now the secondary treatment has improved significantly in stomach cancer with the approval of the drug ramucirumab. Ramucirumab is a drug that starves the blood supply to the cancer. It targets a receptor on the cancer cell called VEGFR2. And this was a trial that my colleague Charlie Fuchs from the Dana-Farber published a few years ago in Lancet. And this was patients with stomach cancer whose tumor was growing on 5-FU and platinum, so it was progressing on 5-FU platinum, and patients were assigned to just best supportive care, just medical care, versus treatment with ramucirumab, this VEGF drug. And not a huge difference, but there were survival benefits for ramucirumab, and patients were on treatment longer, so ramucirumab was able to control the cancer in secondary treatment, and the FDA actually approved this drug for secondary treatment of stomach cancer based on these results. But even more important and more clinically relevant, we don't like to use ramucirumab alone by itself. It's only modestly effective. So this is the Rainbow trial. This is the other trial that showed a benefit for ramucirumab. But in this trial, the control arm, the standard arm, was not just observation. Patients got Taxol. So remember I told you Taxol or irinotecan, those are standard secondary chemotherapies. So this trial, half of the patients got standard secondary chemotherapy with Taxol versus a combination of Taxol plus ramucirumab. And this, again, anytime you see a separation of curves like this, that means the upper treatment is better. So ramucirumab did improve survival added to Taxol compared to Taxol alone. And the average survival time actually approached almost a year. So this trial really set a new benchmark for secondary treatment, that we now had a much more effective secondary treatment. When patients have a tumor progressing on 5-FU and oxaliplatin, we now give them Taxol plus ramucirumab. And the other thing is that responses were better. Patients also had better responses to their cancer with chemotherapy, and nearly 30% of patients had major shrinkage of their cancers compared to only 15% with Taxol alone. So this is now standard second-line treatment for patients with stomach cancer when the 5-FU platinum-based treatment stops working. So we're going to hear results in a few months from Rainfall. This is the first-line trial of ramucirumab, because I told you that this ramucirumab drug is approved for a backup chemo for second-line treatment. This is a large randomized trial looking at standard upfront chemotherapy with or without ramucirumab to see whether ramucirumab works first line. Is it going to make initial chemotherapy better than chemotherapy alone? So just in the last part of the talk, I'm going to talk about the targeted therapies. So I think it's pretty clear from my presentation that chemotherapy does help patients, but the benefit is modest, and that benefits sometimes only last a year or two. So it's clear that conventional chemotherapy has modest benefit. Targeted therapies, these are drugs where we're trying to more specifically block tumor growth pathways in the cancer. Instead of chemotherapy is sort of just a global toxin. It's trying to kill the cancer cell off by poisoning DNA or other pathways. Targeted agents are trying to hit very specific growth pathways in the cancer cell. And targeted therapies include monoclonal antibodies. These are drugs like Herceptin and Avastin and ramucirumab. These are antibodies that block growth pathways. Then there's a class of drug called tyrosine kinase inhibitors. When the growth pathways are activated in the cancer cell, the way that the growth pathways work are through enzymes called tyrosine kinases. So if we inhibit the tyrosine kinase, we may block the growth pathway. Then there are drugs that may be soluble receptors to growth factors that activate the pathways. And then once you activate these growth pathways, down the road, there are all these other pathways that are activated. So those represent all potential sites that we could develop drugs to inhibit these growth factor pathways along many spots in the chain. So I'm going to discuss briefly the Genome Atlas data. These come from Adam Bass's lab in Boston at the Dana-Farber. And actually one of his research proteges is one of our fellowship award recipients this year for innovative work that they're doing in gastric cancer. And a lot of this comes from the Genome Atlas work that Dr. Bass's lab did. So in conjunction with the NCI is trying to categorize an atlas of solid tumor cancers, looking at least 300 tumors for all different cancers in the US. So the gastric cancer genome atlas took nearly 300 fresh frozen biopsy samples from stomach cancer, and they looked at a whole battery of genomic analyses, including gene copy number, whole genome sequencing. So that means they looked at the entire genome of the cancer, looking for mutations and abnormalities. And from this, they showed that in their initial report of 150 tumors studied, there were 26 significant genes in the cancer that were either mutated or affected. So that's a large number of mutations. Some of these have drugs that we might use to target them, including cyclin-dependent kinases. Those are targetable genes, PI3 kinase mutations. So this early report did indicate that nearly a quarter, that there's a significant number of potentially targetable genes in metastatic gastric cancer. So then a more recent publication, they looked at amplified genes. So when genes are amplified, they tend to be drivers of the cancer. And what they showed was that nearly 40% of stomach cancers had amplification of these significant gene growth pathways, including the EGFR pathway, HER2, which is the success story, MET pathway, FGF. So about 40% of stomach cancers have amplification in pathways that we might be able to exploit by looking at drugs to inhibit those pathways. However, clinically, just because you've got a gene amplified, it doesn't mean it's going to work. And rather than go through all the studies, I've just summarized the success to date. EGFR drugs, these are drugs like cetuximab, panitumumab, they've not worked in stomach cancer. They have been failures in clinical trials. Adding these drugs to chemotherapy did not improve outcome compared to chemotherapy alone. The HER2 story, that's been mixed. We have seen some successes with HER2-targeted therapies, but some failures as well. And the MET pathway, we had a lot of hope that the MET pathway was going to be useful, but the drugs that have been tested to date have not shown a benefit. So, but what came out of this analysis is that gastric cancer is not one disease. So it is not one disease. 4 discrete genomic subsets of stomach cancer emerged from the Genome Atlas data. And I've listed these briefly because they have implications in study design and treatments. So one of the more common subsets is called genomically unstable tumors. These are tumors that have chromosomal instability. Probably 95% of esophagus and GE junction cancers fall into this category. And again, about 50% of gastric cancers, this subset applies. These are the tumors that have those pathways, EGFR, HER2, FGF. This is the subtype where we see these pathways that might be targetable. Then a second subset, now it drops to about 20% of patients, are cancers that have what we call a high rate of microsatellite instability. So these are cancers that have a lot of mutations, and these are tumors, tumors that might be good candidates for immunotherapy. We'll talk about that in the second lecture later today. Then about 20% of patients are what we call genomically stable. This corresponds to the diffuse gastric cancers. These diffuse tumors actually have very few mutations. So they're actually kind of bland in terms of mutations and abnormalities. And then lastly, there's a subtype associated with infection of the cancer with Epstein-Barr virus. And this is about 10% of stomach cancers. These may also be a subset of patients that may benefit more from immunotherapy. So what are the treatment implications of these genomic subsets? Let me skip this. Okay. So this just shows the geography of the subsets. Here you've got the esophagus and the stomach. On the left, you see these chromosomally unstable tumors. That's about 50% of stomach cancers and about 95% of esophagus and GE junction cancers. Then the second most common are these MSI-high tumors. These are the high mutation burden tumors. Then in the bottom, we've got genomically stable tumors. These are diffuse gastric cancers that really don't have a lot of mutations and abnormalities. And then lastly, the EBV subtype. These are cancers that are associated with infection by the virus, Epstein-Barr virus, that there may be a lot of immune-mediated mechanisms that we might be able to exploit. So I'm just going to mention briefly here immunotherapy, because we're going to talk about this more at length this afternoon. Immunotherapy, I think, is really the most promising new area of research, not only in gastric cancer, but pretty much any solid tumor. Because I can tell you, I've been practicing for over 25 years, and we kind of brushed off immunotherapy. You know, we used to give patients vaccines and interferon and things that we would try and stimulate the patient's immune system, and we had decades of trials that didn't help patients. Because we really didn't know what was going on. We didn't know why is it that immunotherapies don't work for patients. Because it turns out that we don't help the patient by stimulating their immune system. What happens is that the cancer shuts down your immune response. The cancer actually shuts off your immune response. So it's not that we need to stimulate the immune response, we need to block the cancer's ability to shut your immune response off. And those drugs that do this are called immune checkpoint inhibitors. So why do we have immune checkpoints? Well, your immune system, your body is exposed to the outside world, and you're exposed to foreign bodies and materials all the time. And if every time you got a cold, you had a huge reaction to that virus, or you had a huge autoimmune response, you wouldn't survive it. So your body has to have a mechanism to shut down immune responses, to regulate them. So what happens in the cancer environment is that the cancer cell exploits that, and the cancer cell shuts off your immune response. So now we have developed drugs that block that. We prevent the cancer from suppressing your immune response. And the two main drug classes are listed on the slide here. We have drugs that target the pathway called CTLA-4. On the left, this shows an immune cell interacting with a T cell. The immune cell presents the antigen to the T cell, so you get an immune response. And then what happens is there's another pathway on the immune cell that kills off the T cell. That's CTLA-4. So if you block CTLA-4, you prevent killing off of the T cells, and you get a vigorous immune response. The problem with anti-CTLA-4 therapies is they're very toxic. These patients get severe diarrhea, they get autoimmune reactions, thyroid problems, hepatitis, diabetic problems. So CTLA-4 drugs are pretty toxic. The other pathway is PD-1. PD-1 has been a lot more successful. Again, if you block that PD-1 pathway, your immune response resurges, and you're able to potentially fight the cancer off better. Anti-PD-1 therapies are a lot better tolerated. These are drugs like Keytruda and Opdivo that have now been approved in a number of different cancers. And these therapies have really hit a home run in melanoma, and to a lesser extent in lung cancer and kidney cancer. And now studies are evolving about the role of these drugs in gastric cancer. So this is a slide we always show when we talk about immune therapies. So on the left-hand side of the panel, you can see that's the patients that have lower numbers of mutations. As you go up steadily, as that curve rises, that's the number of mutations in the cancer. And you can see at the top of the scale is melanoma. Melanoma has the highest mutation burden of any cancer. And in order to stimulate an immune response, you've got to present mutations to the cancer. So one of the reasons melanoma is so sensitive to immunotherapy is it presents a lot of mutations to your immune system, and it works. And what I've highlighted there is stomach cancer. So you can see that stomach cancer is probably in the top third. It doesn't have as many mutations as melanoma, but it also is potentially an immune-stimulating cancer. There are a fair number of mutations in stomach cancer. So I'm going to go into more depth about the studies later, but I am going to present really a groundbreaking study that was presented at the GI Symposium 3 months ago by my colleague, Dr. Kang from South Korea. This was a study conducted in Asia. Patients with chemotherapy-resistant gastric cancer that had received all available chemotherapies, and it wasn't working any longer. So these patients really did not have another good conventional option. So patients were assigned on this trial to supportive care alone plus a placebo, because there really was no other treatment to offer the patients. So they got medical care plus placebo versus nivolumab. Nivolumab is Opdivo, that's the anti-PD-1 drug that was administered 3 milligram per kilogram every 2 weeks. And this was a positive study. Remember, I told you anytime you see separation of the curves, that means the upper treatment is better. So Opdivo or nivolumab did improve survival in patients compared to best supportive care. Again, not a huge improvement, but an improvement. 27% of patients were alive at a year compared to only 10 or 11% with supportive care. This is a little complicated slide, but when you ever see a slide like this, and there's a line that goes down the middle of the two columns, anything to the left of the line indicates that the treatment helps patients. So if you look at this, all of the bars are to the left of the line. So this drug helped every subset of patients. So this was a treatment that was beneficial to all patients that were treated on therapy. And time on treatment was also improved, progression-free survival, and about 10% of patients had major remissions. So as I said, it's not a home run, but it is an indication of modest benefit for this drug. And the issue with immunotherapy is if you respond, if you're in that 10% of patients, the responses can be very durable. They can be out a year or longer. So I suspect that Bristol-Myers will probably bring these data to the FDA for a consideration for approval of nivolumab for the treatment of metastatic gastric cancer. So as I told you earlier, these CTLA-4 drugs are much more toxic. We do have some preliminary data combining PD-1 and CTLA-4 antibody therapy. I'll call your attention to the lower part of this table. This combined the drug nivolumab with ipilimumab, and they observed a 26% benefit, 44% in PD-L1 positive patients. So there is a signal of activity for combination immunotherapy, but the problem is it's quite toxic. So what are the ongoing studies of immunotherapy? We'll talk about this later this afternoon. There's actually a post-surgery trial of immunotherapy in esophagus cancer that's ongoing, giving the drug nivolumab after surgery to patients versus observation. There are first-line trials now moving those immunotherapy drugs up to initial treatment of patients. Pembrolizumab is being combined with chemotherapy as initial treatment. First line, there's also a trial of a drug called avelumab given as a maintenance treatment. And then at our center at Memorial, we're running a trial comparing FOLFOX versus combination immunotherapy as first-line treatment. Second line, there are a number of ongoing pembrolizumab studies and a number of other drugs in development, including atezolizumab, durvalumab, and tremelimumab are in development. So I think then just to close off and summarize, in the non-surgical management of stomach cancer, for locally advanced, this is non-metastatic disease, or locally advanced, initially inoperable disease, we would probably give chemotherapy up front, potentially chemotherapy and radiation, and revisit the possibility of surgery later if there's a good response. In patients that have metastatic disease, I showed you data that you probably shouldn't have your stomach taken out initially. I'm not saying it shouldn't be done later, but it shouldn't be done when you walk in the door. You should start chemotherapy first. 2-drug chemotherapies in most patients are preferred, including 5-FU oxaliplatin as the most common regimen used now. Oxaliplatin and capecitabine now substitute for cisplatin and 5-FU, and secondary treatments include taxane, Taxol plus ramucirumab, or the use of the drug irinotecan. For 2-drug therapy plus a taxane, we probably shouldn't give 3-drug treatments to patients over the age of 65, and epirubicin I really think should not be given to patients. We should not use this drug anymore. Targeted therapies, we've made progress. I didn't talk about HER2, but we have trastuzumab as an approved drug, and hope to hear results from a drug called pertuzumab shortly. Immunotherapy looks promising, and we now have a positive trial for nivolumab, which may lead to approval of this drug in the treatment of stage 4 stomach cancer. Thanks very much.
Thank you, Dr. Ilson.